Please.
Thank you, sir, for the opportunity. And it is a wonderful course wherein a lot of things are to be learned. And I myself listening to all the speakers to add a few points to whatever I understand about the measurements in eye trace. What I'll be talking will be regarding selecting patients for multifocal IOL based on eye trace. There'll be a little bit of overlap in terms of the basics of selection of cases by eye trace, as has been discussed earlier. So for a multifocal lens, the key for success is a good patient selection. That is the most important thing. And that is what we would like to do by use of eye trace. And then, of course, accurate biometry, power calculation, and the surgical technique has to be done. And then, of course, you have to look at the social and occupational factors, like the patient should not be over demanding and shouldn't have unrealistic expectations. And, there shouldn't be occupational light drivers. The astigmatism shouldn't be very high. There shouldn't be any pre-existing ocular pathology or any previous history of refractive surgery, and individuals with a monofocal lens in the other eye also sometimes may be encouraged to have monofocal in this eye as well. And the basic reasons for dissatisfaction with multifocal IOL is IOL misalignment, or residual lens fraction, or posterior capsular opacification, or ocular surface disorder, or there is some deviation between the optical center, what I mentioned as IOL misalignment. So eye trace is a useful tool for patient selection for multifocal IOL, and I'll just go to how it helps. Now, as has been mentioned earlier, that eye trace measures the aberration of the eye, and it not only measures the aberration of the eye, but it dissociates the aberrations of the cornea and the lens. And that is the advantage, that if there is predominant lenticular aberrations, then in that case, you are removing the lens. So you can put multifocal IOL because there's no aberrations left. And if it's a predominantly corneal aberrations, then you cannot put a multifocal IOL because there's so many aberrations. So if there's a relatively high corneal higher order aberrations, as seen in this case, in that case, one should avoid multifocal lens. And if there is a low corneal higher order aberrations, then in that case, you can put multifocal lens. So it is very essential to dissociate between these. As you can see here, the quality of vision because of the lenticular internal aberration is very high. So in this case, once you do a cataract surgery, you can put a multifocal lens because the corneal aberrations are not high, and that way you can improve the outcome. So that is one thing that one should definitely see when you are doing eye trace for multifocal lens. The second thing that one can do is that because of the dissociation of the eye trace of the lenticular and corneal aberration, sometimes what happens that you can see a significant lenticular aberration. There's a little bit of corneal aberration. When you examine the patient, there's no presence of any corneal opacity or any degeneration or dystrophy. So maybe it's an ocular surface disorder. You do a breakup time. If it's low, treat the patient for dry eye, do eye trace later, and you will definitely see a significant improvement in all these cases. And once the dry eye is handled, once the dry eye is treated, then in that case, and the corneal aberrations improve by treating the ocular surface disorder, you can go ahead and put a multifocal lens. Then the third and most important thing is the optical alignment, which is very, very essential in a case of a multifocal lens. Now, there are two entities, angle alpha and kappa, which has been discussed earlier also in previous talks. There are several methods of measuring angle kappa that you can use synoptophore, you can use OpScan, you can use eye trace aberrometry, but angle alpha is measured only by eye trace, and it uses millimeters as measurement unit for angle kappa and alpha. As you can see here, now this red point is the center of the visual axis. This is the corneal center. Corneal center means center of the limbus, and that will be the center of the bag as well. So the IOL centers along the center of the bag. So the center of the IOL will be coinciding with the center of the bag. So this is the center of the IOL. And this is the pupillary center. So the distance, as it is measured in millimeters, so the distance between the center of the visual axis and the corneal center is angle alpha, and the distance between center of the visual axis and pupillary center is angle kappa. The angle kappa is important for refractive procedures, cornea-based refractive procedures, because most of the trackers, they track the eye and align the eye based on the pupillary center. And if the visual axis is too much away, then if you do an ablation of the cornea, then there will be induction of aberrations, because your ablation should be centered onto the visual axis. So that is important in corneal refractive procedure. But when we talk about the cataract procedure, the IOL implantation, in that case, the corneal center is important, because the center of the limbus or the corneal center is the key, because the IOL centers at the corneal center. And there should be a great difference between the visual axis and the corneal and the IOL center. So as I said, angle alpha is the difference between the center of the limbus and the visual axis. Angle kappa is the difference between the center of pupil and visual axis. And angle alpha is very important for screening premium IOL patient, because if you are put a diffractive and if it's a high angle alpha, in that case, instead the light refracted from the central part, the central rays will refract from the diffractive plates, and that will induce aberration. As in this picture, if this is the optical axis, now this is the optical axis of the lens, and if this is the visual axis, then the rays are focusing on the diffractive plates, and that is why there will be induction of aberrations. And that is why ray tracing device color codes the amount of angle alpha. And the angle is, if the angle is less than 0.3, it is green. If it is 0.3 to 0.5, it's yellow. And if it's greater than 0.5, it is red. And so that is why if it is more than 0.5 millimeters, then multifocal, it's a big no to multifocal. 0.3 to 0.5 is a gray zone, which depends on the type of multifocal that you're using, the type of central optical part, this central optical part, which varies with different IOLs. So this is a gray zone wherein if you have an angle alpha of 0.3 to 0.5, then you have to select the appropriate size of multifocal lens, because the current generation multifocal lenses, some of them have a 1.3 millimeter of the central zone, and in that case, the basic idea is that the IOL should be centered in such a way that the rays, the angle alpha should be half of the central cylinder, central optical cylinder. This is one interesting study which studied on the, I'll just have 2-3 more slides. So this is a very interesting study on the angle alpha in cataract patient population, and they found out this was an analysis on 8773 patients, and it was limited to the first right eye scan of 3382 unique patients. The mean angle alpha amplitude was 0.44, and angle alpha orientation was predominantly horizontal. And so that is why they concluded that angle alpha is a predominantly horizontal phenomenon with the mean expected point of IOL centration 0.44 millimeter temporal to the visual axis. So that is why, as I said, that it is the importance of optical alignment is very high. And this study by Waring et al., they have suggested that multifocal IOL should not be implanted if the preoperative angle alpha is larger than 1/2 of diameter of the central optical region of the multifocal IOL, which I was mentioning earlier. So just a couple of examples, like this is an extremely high angle alpha, as you can see. So it's a poor candidate for multifocal IOL. You can see angle alpha is 0.729. So it is a poor candidate. This is a borderline one. Angle alpha distance is 0.426. So you have to select that specific IOL. So it is a gray area wherein you have to select the IOL. And if the angle alpha is 0.098 here, which is almost coinciding with the visual axis, so it's a good candidate for multifocal IOL. So in conclusion, multifocal IOL implantation is a tricky situation, can be very satisfying, or it can just be reversed. The patient can be very unhappy. So proper planning and case selection is important, and iTrace is a useful tool in planning and case selection for cases of multifocal IOL. Thank you very much once again for your patient listening.
Thank you, Dr. Rajesh, for your excellent talk.